Thank you, everybody. Welcome. I'm Bart from Belgium, the best beer country in the world, as we all know. But we also do pretty mean physical therapy there. So I'm a physical therapist. That's me. If all goes well, you can see that. That's me. Already old, 50 years plus, but don't tell that to anybody else. I've been working a lot in seating people with disabilities for over 27 years. I have my own clinic, and I also do training and seminars all over the world under the name of Super Seating. So that's important to know. I also want to disclose that, I have the clinic, the private practice, Super Seating, but I also am the inventor of the concept behind Modiform, which is a mobile arm support, and that is manufactured by BodyPoint. It's very exciting. So I just want to share that with you. That was a concept. So here are the session goals. I think we all going to skip that because you know all this from your handout. And I want to start with my uncle, the best uncle in the world. And unfortunately, this is him in better days with his wife, Anna. And the problem was that he had a stroke, and he was, as a result of this stroke, he had a subluxation of his shoulder. The shoulder became a frozen shoulder, painful shoulder, and that was in the early phase of rehab, and you don't have a lot of window of doing rehab. So we lost 3 months there, and I helped him with his shoulder mobilization, and then we lost time for a lot of time in the rehab. And I said, well, this is ridiculous that we are so skilled, we are so good, and we are the best in the world, and we still have seating complications like shoulder subluxation and frozen shoulders. So I said, this is ridiculous, and we have to do something about that. So is your client at risk? So I'm just going to give you a little bit of the basics. If you have range of motion deficits, contractures, range of motion deficits, if there is a subluxation that you already see, for instance, a gap between the acromion and the head of the humerus, if there is upper extremity pain, if transfers are difficult using the upper extremities, if there is a 24-hour postural management of the upper extremities that is not being considered, and if there has not been a seating eval, your client is definitely at risk. Because the goals for upper extremity management is to manage contractions, tone, reduction of shoulder pain, improve function, proprioception, strength, also absorb tone over time, and then minimize unwanted movements in early rehab or whenever it's appropriate. And it still doesn't happen. We see so many people with, for instance, glenohumeral subluxation. This is a friend of mine. This is an unfortunate accident that he had. He had a spinal cord injury, and he also had a stroke afterwards. So if you can, the incidence of glenohumeral subluxation is 17% to 81%, depending on how you count them or if you count them. So it's a big deal, and it can contribute to tears and shoulder capsule damage. But contractions are also possible, and up to 84% of people with TBI, traumatic brain injury, they develop contractures, and that results in shoulder pain, subluxation, contractions, and affects the quality of life, function, and it increases your time in rehab. So it's horrible that that still happens. So this is also a client of mine with, and you can see from the posture that it's easy to get there, so. But we get into that. So pain affects a lot of people post-stroke, 16 to 72. So a lot of variation there. Probably is difficult to measure, but it's also common with people with spinal cord injury, traumatic brain injury, muscle dystrophy, MS, and Parkinson's disease, right? And this is a subluxation. As you can tell, the head of the humerus is way down on the compared to the acromion. So there is often a weakness of the deltoid muscles, and then the rotator cuff muscles are stretched. And those are supraspinatus, infraspinatus. I have them all here. So those little things in yellow, you can see supraspinatus, infraspinatus, teres minor. The tendons get stretched, the muscles get stretched, and also damage of the capsules is possible. Okay, so we have some seating considerations. We lost a slide here, which is no problem for me. But if you think about it, it's normal that people have seating complications with the upper extremities, because if you have no deltoids, and you have a very small area where you make contact with your upper extremity on the arm support, which is basically this red thing on the skeleton, that's right under the humerus, that's a very limited space. Because if you have a wheelchair, you cannot design the arm supports of the wheelchair to have more contact area, because then you cannot transfer in and out of the wheelchair anymore. So you only make a very small area of contact. You often have a kyphotic posture, and then you have an internal rotation because your pectoralis are short, and then you end up with a upper extremity contact area, which is about the size of your fingers, right? How much would that be in square inches? I don't know, but it's not much. And what happens? It's on your forearm. So if there is contraction tone or lack of posture mobility, posture control, your arm slides forwards on the arm support, and it's suspended without any support. And then you have all these complications. But you also can imagine that if that happens, there is a whole chain of things that will happen, because what you also see is that now the hand is unsupported. So all practical cases that there's small contact area, compression of the rotator cuff tendons, there is stress on the capsule, and the hand and the forearm are uncontrolled in uncontrolled positions. And if you and there's also, if you lean, or if you go in a kyphosis and you lean on your elbow, it's basically compressing that space, and it can actually squeeze the rotator cuff muscles under your acromion. So horrible things. Let's go into the pathomechanics real quick. Well, contractions, when you have a loss of contraction, when you have contractions, range of motion deficits are very likely. And we see that range of motion deficits can occur very quickly in the course of days. And we see that it's very, very often present with people with central nerve system damage, not just stroke, but also people with traumatic brain injury, suffering traumatic brain injury. And muscle weakness always goes hand in hand with loss of motor function. And then we also have spasticity, which is often present. And that leads to a whole chain of fixed positions of your upper extremities. And then a lot of people say, yeah, well, if I want to support the hand, or if I want to prevent a contraction of the hand, I need to work at the hand. But it doesn't make any sense, because this is actually the hand muscles, and those are very limited. But the muscles that are responsible for contractions are basically multi-segmental muscles. So they are attaching on the distal humerus. They extend at the forearm. And if they are contracting, they, the flexor digitoris profundus, carpi radialis, ulnaris, and flexor digitoris superficialis, they will contract, they will cause a wrist flexion and a finger flexion. And then the extensors is the opposite side, but you see where they are. So the key to supporting the hand is not the hand, it's basically the forearm and elbow. And this is where we got it wrong, because we make then splinting. And if you're lucky, we do splinting. Nowadays, back in Europe, splinting is becoming difficult because we don't have a lot of knowledge to do that, or time. And there's also something like the MDR that is saying that if you're making equipment to measure, you basically should document that, and you should trace where it goes, because that's safety for your clients. So there's a lot of paperwork involved. So we don't do that. But you can see that often when we do splinting, the splint stops at the forearm, mid-forearm. So that basically means that the elbow is free to move, and especially if there is a contraction of tone or a tone issue, well, basically your elbow can compensate. And if your elbow can compensate, your shoulder is unsupported. So you have basically 2 points of support, your hand and your wrist. So that's not enough. Never works. And also, once you've done the splinting, it stays in the same position. Well, and then a lot of people say, well, yeah, I can also do something like a trough, like an arm trough or a gutter where I place the arm in. But, you see where that goes. It basically is aligned with arm support. So it's basically stretching your pectoralis. It's not a physiological position to sit like this. You want to sit more towards an internal rotation with your shoulder. and your hand is completely free to move, right? So that doesn't make sense. And pillows, well, have you ever kept a pillow at somebody for a whole morning? Impossible. The pillow compresses, moves forwards, or slides from the lap. So difficult. It's really difficult. So it goes wrong, and then you have often complications like subluxation. Unsupported fingers, unsupported wrist, and unsupported forearms, and we have problems all over the place. So what do we need to do? Well, I said, well, this cannot be the case. We need to find a better way to position the upper extremities. So what happens if you follow the neurodevelopmental treatment approach, where you avoid sensory input that causes flexion, like stretches? So you put the upper extremities in an anatomical resting position without stretching the capsule and putting the joint into a neutral position. So you don't have a lot of input from sensory information from your capsules that is causing a stretch, because the stretch is causing a reflex towards the contraction. So you want to do that. And you also want to have 3 points of control to support your hand, your thumb. You support your thumb in abduction and extension, your forearm in supination or in a neutral supination, and you basically put your wrist in a neutral position, almost like you would grab a cup of coffee, or politically incorrect, a gun. You know, so if you have a gun, it's more or less the same thing. It's very comfortable to do so, a bit dangerous, but you know, that's how we do it. That's basically also if you are basically mobilizing a client with a fixed or with a flexion contraction of the fingers, you will slowly work your fingers towards an extension, and then you do an abduction of the thumb, and then you put in the wrist towards a neutral position, and then you put your forearm in a neutral position. That's how you mobilize people with tone. And I think, you know, that would be a great thing. So that got me started. So that was like my uncle got it, and I said, how come that this is still possible? And then I said, well, I'm going to build something myself. So I always do this when something is not there, I build it myself. And I started playing around. And so, well, I need 3 points of support. I need to support the shoulder by supporting the elbow. So if I control the elbow, I will control prevention. I do prevention of subluxation. I make sure that we position the forearm in a way that there is no stress on the capsule of the glenohumeral joint. Then I also need to be careful. I need to make sure that even if I support this, I also need to support a distal forearm. Because if I don't control the distal forearm, the wrist can go in flexion or extension. Most of the time it will go in flexion. And if the wrist goes in flexion, your fingers go in flexion. So I need to control that. And then I also need to control the fingers and the thumb in abduction and extension. So we are having less sensory inputs to go into a flexion pattern. And then I came up with the shape. I looked at anatomical resting positions, tone inhibition movements, and then I came up with a board. And that board had a plastic, and on top of that plastic, you had a foam to have padding, and you can adjust the place on that board, and then you can position on that board the hand block. And the hand block was initially made from foam. So that's actually because you could squeeze it a little bit. So I wanted to have some dynamics in it, because if you have tone and you let the distal segments move, then you keep control of your proximal segments, which is very important. You want to keep control of your shoulder. So if you allow some movement of the fingers when there is tone, which is difficult to inhibit because you have people with a central nerve damage, then you have a better chance of maintaining the upper extremities. And then the project got started. I also know that I'm very creative, but I'm not a good manufacturer. So well, I'm not going to do that. So the friends at Body Point have then taken this to a new level and have made a fantastic product with 3 points of support, completely in line with the concept, that absorbs the distal fingers. So as you can see on the right, you have movement there. And that's basically the concept that was initially thought out, right? So very exciting, and it's often forgotten. So I hope we don't do this anymore. Thank you for your attention. Right.